Good afternoon, ladies and gentlemen, and welcome to the afternoon session sponsored by Valve Technology. The session title is A Problem and a Solution, Aortic Regurgitation and the Trilogy TAVI Valve. The team probably doesn't need any introduction, but my name is Eberhard Grube, University Bonn, and we have a very esteemed team of discussions and presenters, Dr. Matti Adam from Cologne, Joan Cavalcante, Professor Trede, and Dr. Marty Leon. And for me, it's an honor to substitute for Dr. Zamorano because she got stuck in Madrid. So with that, I would like to start with the learning objectives as requested by PCR. We have to understand the challenges of imaging for aortic regurgitation and how it can lead to underdiagnosis, something that Dr. Cavalcante will address. And then from Dr. Leon, we will hear the data from the ALIGN AR trial that studied TAVR and aortic regurgitation patients, and also to learn about the Trilogy valve and the future of TAVR for patients with aortic regurgitation. I think this is going to be a very interesting session. I hope that we will have a good discussion after each individual presentation, and then we do the final wrap-up. So, João, maybe we can ask you to start.
Well, thank you very much, Eberhard and Valve for this opportunity to present here on behalf of Minneapolis Heart Institute on this topic that we are so all passionate about and a lot to learn. So the objective here is to understand the burden of this disease, the underdiagnosis and the treatment, and how can imaging hopefully help in our understanding. And some of these disclosures here relevant to this topic that I work also in the consulting capacity for Valve, and Core Lab has received some also research grants for its understanding. So I thought about dividing into these four quick topics here: understanding the prevalence of aortic regurgitation and the quantification challenges, how these problems can lead into the undertreatment, and some future directions and take-home messages that we could do. So let me start by asking this question here. Maybe with the raise of hands, it's a little bit dark, but who thinks that significant aortic regurgitation is more common than significant aortic stenosis? Moderate to severe aortic regurgitation is more common than aortic stenosis. Who thinks that's the case? Few
okay,
hands
we see
here, but
some hands up.
from the industry, I guess, you don't count, okay? So if we skip that, okay, let's take a look at the data. So we got to look into epidemiological data. So this is Oxvalve here in UK, 2,500 patients, 65 and above, that they were screened for valvular disease. And you can see here the prevalence of moderate to severe was 6.4%. Number one is TR, number two is mitral regurg, and number three is aortic regurgitation. Aortic stenosis is actually 0.7%, so it's half of that. Okay, I can't believe this is UK. Let's go to United States. United States, we have this Heart of New Ulm that was recently published in JACC Imaging, maybe not representative, obviously, to the uniqueness of the demographic. So white Caucasian population screened for valvular disease. Top three are TR, MR, and AR. Same degree. And what about the aortic stenosis? 1.6%. Significant valvular disease, 10 years older, was actually much more than the Oxvalve. So we see the same pattern. But where are these patients then? Where are they? Because we don't see them. Well, let's go to China. We know that from China, the aortic stenosis bicuspid valves are much more common. But we see even here when they exclude bicuspids and degenerative heart valvular disease, the top three are AR, TR, and MR. About the aortic stenosis, 1.1%. So we have a problem that maybe they're out there in the community but not making to the hospital. If we screen them, maybe we'll find. And not everybody obviously deserves treatment, but we deserve at least monitoring and understanding of that. So I would like to start by showing a case to highlight the difficulties that we have. This is a 79-year-old retired psychologist and dance instructor that presented with exertional dyspnea. She was hospitalized for heart failure. She had class 3 symptoms. You can see a very high BNP. mildly hypertensive as well, with preserved ejection fraction, normal LV size. The end-systolic diameter index is 2.2. She has moderate AR on the report by echo, but there is no mechanism of aortic regurgitation. And she obviously had kept progressing with heart failure. The kicker here is that she has a history of radiation heart disease with Hodgkin's lymphoma, and this obviously has caused some potential changes in her heart as well as in the coronaries. When we look in her echocardiography, these are the images. This is real world. I mean, despite the best optimization, zoom in on the parasternal lung axis, you can see that I cannot define what the mechanism is. I do not know, I cannot see where the vena contracta width, I cannot measure. Maybe the diastolic flow here is not as dense as the systolic, but I can make a measurement of pressure half time, which does not mean much in chronic AR. I can make some measurements of PISA that all of that concludes that this is not severe aortic regurgitation. Now, what about the ventricle? Well, the ventricle, by these measurements, is not dilated. The ejection fraction is preserved. You can see here 62, and the end-diastolic volume or end-systolic volume do not meet the thresholds. So she is quite symptomatic, yet the ventricle is not dilated, and the aortic regurgitation is not severe, or felt not to be severe. There is a disconnect between what she presents with. Well, let's take a look at what the guidelines would have said. Well, you have to have, obviously, symptoms, and you have to have severe. She does not have severe yet. You got to go further. What do the guidelines say? You got to measure a bunch of stuff. And this, honesty, it gets too complicated for a mundane and for a regular use in the echocardiography lab. It requires us to do several measurements without a hierarchy. So I don't know which one should I weight more to indicate that. The guidelines also make a point that good quality data is necessary and assumed, which is not always the case, as I just highlighted to you. And in some cases, the aortic severity can be indeterminate, and therefore TEE or CMR should be considered. Well, there's a roll of the dice. How often can I get the parameters when I try to measure them? Well, not commonly. So pressure half time, perhaps a little bit more. But when you try to look, for example, flow reversal, which is very specific, less than a quarter of the patients I can get that to be conclusive. So my take-home message, first one, is please don't stop at moderate aortic regurgitation. Always take a further look, because it could be moderate, but it could be more than moderate, and you don't want it to miss that opportunity. Just because it's moderate, it's because I do not know how bad it is. I can tell that it's not mild, but I cannot tell how severe it is. So this patient underwent a TE, and as you can see now, the jet is much more clearly visualized. You can see that they're thickening of the cusps, and there are two jets, one very central, another one between the nun and the left. You can see that there is obviously, by now, the pressure half time much more significance, perhaps, although, again, in the chronicity of the AR, the ventricle is going to dilate. There's flow reversal in the proximal ascending aorta and a PISA that suggests this to be more significant AR. Let me put a plug for, obviously, MRI, which I think is the way that we should be practicing in some of these patients, and perhaps even more so than what we do. That gives a capability to see not only the valve, the ventricle, the severity of the AR, which all will be important to make a decision who and when things should be done for these patients. Guidelines say that we should consider, particularly when there is a situation when the Doppler and the AR severity is equivocal, the quality is suboptimal, but they acknowledge that CMR provides the accurate and reproducible measurements of regurgitant volume and fracture, which is ultimately what we do determine who needs to be intervened. So when in doubt, check it out. How does it look when we compare severity of aortic regurgitation of echo versus CMR? This is a recent publication that has come out in JACC, a multicentric study looking at side-by-side. Basically, about a third of the patients that CMR was unequivocally called severe, they were felt to have mild or moderate by echo. So you're going to be undercalling, not in an insignificant percent of patients with a very poor agreement. So we need to do better. And this is not to point a finger at the echo, it's just to recognize the limitations, and particularly because of the eccentricity of that jet and the difficulty for us to be aligned in front of the jet for us to see it better. Well, we missed the opportunity because we did not hear murmur. It's hard to hear that murmur. We missed the opportunity because it's hard to make the appropriate diagnosis of significant AR. So we missed the bullet. It was fine. The ventricle is fine. I cannot see it. Well, by the time they become symptomatic, the ventricle is beyond symptomatic. So by the time they get referred to surgery, which is when symptoms occur, a lot of these patients don't get operated on. If they get operated, that's the red curve, they do better than when they don't get operated. Of course, there is a selection bias. This is not randomized. But needless to say, they don't get referred to surgery that often. And that's a problem. So our first question is how common that is. It's probably because we're not making a proper diagnosis. So the number that ultimately get intervened on is quite a small number. So this is a consequence of, obviously, of all these factors. The Align AR, you're going to hear from Dr. Leon here very soon. As you will see and probably discuss, the number one cause of screen failure was actually the fact that the AR was felt to be non-severe. So patient symptomatic, but you go there, well, it's not severe, stop. Second reason, obviously, the anatomical exclusions. Could we have done something else to rescue some of these patients? So this patient got the TE, got the CT, and you can see that the annulus is suitable for the treatment. The transfemoral access is possible. But even looking at the CT, not only from the anatomical aspect, but also looking from the functional aspect of it. This is aortic insufficiency seen through the CT lens. You can see by volumes that the volumes are significantly dilated. For a female, it should be below 92. This is much greater. The ventricle that was felt to be normal EF is actually dysfunctional. You can see that there is a wall motion abnormality along the RCA territory here. Why? Radiation heart disease and proximal CTO of the RCA. So there is infarction and ischemic cardiomyopathy, and there is incomplete coaptation for this valve. Now, I want to put a plug also for work that we are doing, and thanks for the, obviously, support from London Valves and Stephanie, who is going to be presenting this on Tuesday, looking at how much could CT and MRI rescue these patients if we had done that. This is a case series from our center in which we look at this case here, moderate aortic regurgitation from the quantification, but when we look in the CT, the same patient, you can see how big that hole is. That's the regurgitant orifice area that reached 1 centimeter, and this ventricle is significantly dilated. So could we have used CT much better? We know that MRI can do a great job, but even using CT as an arbitrator here could have rescued some of these patients, and we'll please come by on Tuesday to learn more about that. So this patient ultimately got into the Align AR. This is a 23 millimeter London valve, and you can see with the markers you can do a nice commissure alignment, and Dr. Leon is going to talk much more about that, and no paravalvular leak. This patient also was followed with a follow-up CT at 30 days with excellent leaf mobility, nice commissure alignment, and single gradients for this valve. There is also another system that is now on the trial, the EFS with J-valve. And I think in the future here, we need to consider that as we're talking about volumes, we need to understand that there are going to be also gender differences. Women start with a smaller heart than men, but they don't dilate to the same extent as men do to the same degree of aortic regurgitation. So if we're going to use volumes, let's please maybe consider also index volumes not only to body surface area, but for gender, because there will be a penalty. Fibrosis is going to be important, whether this is non-ischemic or scar-related. These ventricles are already feeling it. And to intervene in the absence of symptoms, we should also be critical about the guidelines. These linear dimensions that were developed in the 80s, they come at a penalty. If you look at data from both Cleveland Clinic and Mayo Clinic, the inflection point is not at 2.5 or 25 millimeters. It comes much earlier. So the guidelines are outdated, and they're coming at penalty even for those that are asymptomatic, let alone for the symptomatics. When we look into the patients that were presented here from the IGNITE, patients with moderate or severe, so that goes to show that the discrimination of AR severity is tough by echo. What determines the outcomes is actually the ventricular dilation. Maybe 25 or even 20 would be better. When we look at by MRI, 25 does not discriminate. This is by echo. 20 is better than 25, but still better for volumes. And volumes by MRI is much better than by echo, in addition to the quantification of AR severity. So in summary, I would like to just leave you with this case. That is a patient of mine from a couple months ago. He is asymptomatic. He was have moderate aortic regurgitation. I said, let me just take a look at the MRI. So I'm preaching out to the choir. So take them to the MRI. You can see that by dimensions, he does not meet the threshold yet, 23. But when you look at volumes, he's significantly dilated. He has severe aortic regurgitation, as you can see here. The strain is already impaired, and the ventricle already has fibrosis. So the patient may be asymptomatic, but is the ventricle asymptomatic? And do we have enough tools that we could potentially use that and leverage for a treatment decision of that? So let's close to say that significant AR is not uncommon, but it's terribly underdiagnosed. And remember when the TR was the forgotten valve? That's the same thing that we're facing right now. The 2D echo is inadequate for quantification of AR severity and for LV remodeling. We should forget linear dimensions. Who still practices the same way that practiced in the late 80s? Nobody. The treatment has evolved, yet we are using the same thresholds. Despite patients having this long asymptomatic period, the left ventricle is feeling it, and we should be intervening into that, especially if we have much more safe and effective treatments. The current devices will not deliver adequate results, and we're going to hear specifically about the valve. And the current goal ultimately will be to address, not right now, patients that are high risk or inoperable, but moving the goalpost further into asymptomatic patients, into even moderate, quote unquote, aortic regurgitation will be necessary. Thank you so much.
Thank you very much, João. And we have a couple of minutes for discussion. Obviously, what we can see is that we have not only a problem, but now that imaging is getting better, we shouldn't miss the point of intervention. The problem is, and you pointed that out, the difference between echo, CT, and MRI. So when should we start? If we see a patient, when should we start to worry? Meaning, when should we start the interaction with imaging? At what point? Do we wait for symptoms? Do we do echo? Do we do something else? What is the point that we shouldn't miss?
Yeah, maybe the way we practice, and I particularly practice for this group of patients, and I would like to hear from the other panel members too, is for patients that have severe aortic regurgitation on the echo, if the ventricle is not dilated, I try to get objective volumetric data. Because if the echo is already severe, the severity is already unequivocal, for me, I tend to expedite the care and the patient being symptomatic, yes. If a patient has moderate aortic regurgitation and the symptoms I cannot be certain, I get an MRI. I think it's much better than trying to get stress echo. For example, for me, the echo part, or even a stress treadmill, is to objectively assess their symptoms. The problem is that they can do for quite some time. The ventricle keeps adapting. They tend to be bradycardic, which is actually worse for the ventricle because there's a long diastolic filling time, and they can go for quite a while. So maybe if I'm going to use treadmill, it's going to be just to see. In 2023, they could exercise for 14 minutes. Now they are down to 10 minutes. There is a change, objective change. But I use biomarkers. I use MRI much earlier on, especially these moderate. Some of these moderate might be severe. And if they have severe and the ventricle is dilated, like the one I showed, I already have enough here.
Yeah. So, Marty, severe and moderate, that's the magic word. Obviously, the ventricle plays a role. Are we sure when aortic regurgitation is severe and moderate?
Again, I think right now we use the terms moderately severe, moderate, mild, and it really varies because with the regurgitant lesions, obviously, depending upon blood pressure, depending upon other situations,
right,
volume status, catecholamine levels, heart rate, these distinctions as to severity are really not uniform and they're not rigid. I want to go back just a bit and just make a few comments. I'm old enough to have been with Bob Bono at the NIH when we did the natural history studies in patients with aortic regurgitation using linear dimensions to create the cutoff values that would allow us to operate on patients at that time we thought was earlier. Those studies were based upon the fact that when you waited and determined a point, when you did surgery and the patients no longer recovered well, that became the cutoff point. So obviously we waited too long. But what is, to me, incredible is that now we're talking about 40 years ago, that the indications, the guidelines with respect to LV remodeling and LV function have not appreciably evolved. They've remained static. They've remained essentially unchanged. And I think that now is an inflection point because with great deference to my surgical colleagues, especially Henrik, who's sitting right next to me, you need to have a less invasive, easier therapy to apply to patients at an earlier time to really change the cycle that we've been in. So I think now we're going to see some real changes. I think if you see moderate AR on an echo, you should get a CMR. You should follow patients every 6 to 12 months. You should do an exercise test. You should get biomarkers, and you should clarify their overall clinical status as you follow those patients. With respect to prevalence, I want to tell you we don't know the prevalence of regurgitant valvular heart disease. This is all illusion. We know the prevalence may be if you happen to live within 50 miles of the Mayo Clinic in Olmsted County, but not the prevalence anywhere else. And we are in the midst now of doing a study called Preview Valve, which is a large prevalence epidemiologic study in valvular heart disease, where we use CVS pharmacies in the US to identify individuals who are over the age of 65, and then we go to their homes, we get echoes, we get biomarkers, we get ECGs, we get blood work for biobanking, and we're now beginning to do what is a very interesting and very different epidemiologic study on valvular heart disease. And I will tell you, the regurgitant lesions clearly are more prevalent than the stenotic lesions, and the lesions that affect the AV valves probably more so than the aortic valve. But we'll have much more prevalence data over the next 2 or 3 years. And lastly, we also did the same thing that the Mayo and the Korean folks did on using ECGs to do early diagnosis of valvular heart disease. And we've done the same thing with all left-sided heart lesions, AR, MR, and AS. And they're all equally about the same in terms of sensitivity in being able to use a standard 12-lead ECG to have a better understanding as to whether or not there's a likelihood of significant valvular heart disease that would, again, trigger an echocardiogram and into more of a clinical pathway. So there's going to be significant changes over the next 5 to 10 years, at least I think.
Yeah, I agree with you, Marty. And maybe, Hendrik, a quick word on what would convince you to operate on a patient with, what are the criteria to operate on a patient with aortic regurgitation?
Well, basically, it's a simple operation, so it's not so much about the operation itself, it's about the patient. And many of those patients then being presented are clearly TAVI candidates, have always been, but we didn't have the right devices. And sometimes we were found of operating on patients we didn't want to operate on because there was just no other choice. Then there's, of course, comorbidities. You know, AR is very often combined with bicuspid valves, is very often combined with aortopathy. And then, of course, surgery again plays a role. But since we now have dedicated technologies to treat at least tricuspid AR very nicely, I think that's also a relief for surgeons because I don't want to operate on all of those. Clearly, in young patients, you could also discuss the repairability of valves and stuff, but this is not what we're talking about. I mean, I don't know if you have shown the age distribution of those patients that were found in these studies in China and in Cambridge and wherever, but I guess these have been pretty old patients, right?
Yeah, so the Ox valve was 65 and above, and mean age was around mid-60, 68, 69. And for our study at the Honu valve and the heart of New Ulm was above 75. So yes, and the mean age for our line is around 75. So there is definitely these two groups, right? The young bicuspid patient with sometimes aortopathy mixed aortic valve disease or predominantly AR. And then there is the other population that is a tricommissural tricuspid valve that, the valve is degenerative and does not close. Those are the ones that I think, we are probably acting way too late. And
okay, quickly, because we have to move on. Hendrik, what kind of technique do we have today for aortic regurgitation?
Well, there is repair, but you would not repair a 75-year-old. At least I wouldn't do. I know some people do, but I don't think it's a good idea actually. Since we have the possibility of a valve-in-valve, I would rather place a perfect biological valve. These annually are large, so you get always a large valve in, and then you have a long lifespan until you then do a valve-in-valve. So I think the threshold of doing a replacement is very low when it comes to elderly patients.
Okay, thanks. So Marty, next to you, and you will be discussing the Align AR study. The title, I guess, Solving the AR Problem, the Trilogy Valve, and the Align AR Study. Pleasure, honor, and what else?
Thank you, Eberhard. So this is the only venue when Align AR is going to be discussed at PCR London Valves. So I'm going to spend really the bulk of my time discussing this trial because I think you all should have an opportunity to look at the data and ask questions. And I'm really doing this on behalf of the two co-principal investigators, Vino Thorani, a cardiac surgeon from Atlanta, and Torsten Wahl, who is originally German and has been working with us at Columbia for about a dozen years, and for all of the Align AR investigators. These are my potential conflicts. I do not have a relationship with JenaValve. You've already seen a little bit of the background. Clearly, untreated, severe, symptomatic AR is associated with a high mortality, especially if it's in the presence of severe cardiac symptoms, whether you use New York Heart Association class or other measures of severe symptoms. Currently, surgery is the only recommended intervention for these patients. There are a few treatment options for the high surgical risk patients, and the previous off-label use of TAVR devices for AR has been associated with certainly high rates of complications, including paravalvular leak and valve embolization. And this is simply a summary of some of the key studies demonstrating that there is a rapid decline in vital status in patients with severe symptomatic AR, untreated, especially if they have class 3 or 4 symptoms. The valve we're talking about is the so-called Trilogy valve, and I want to make some comments about this, and hopefully we'll have a little discussion later on. This is a short frame, self-expanding device, which is particularly stable. It has a tri-leaflet porcine pericardial tissue valve on a nitinol frame. It's available in 3 sizes with a perimeter range of 66 to 90. It also has this clipping apparatus, so-called locators, that goes behind the leaflets and fixates the valve at the leaflet level and ensures commissural alignment once it's properly located. And at that point, very open cells facing the commissures or facing the coronary arteries, so coronary access is not an issue. There's also a flared sealing skirt at the inflow and very specific pre-shaped sheaths and a delivery system that allows you to be able to control the device, rotate the device for positioning and whatnot. So this is a different, highly differentiated TAVR system that has been used and was developed both for aortic regurgitation and aortic stenosis, but very different properties, and the device itself is, for the most part, intra-annular. Keep this in mind when you see some of the results. The deployment of this device is fairly straightforward. Once you bring it across the aortic arch, you have to align it to the 3 sinuses, and there are very specific algorithms that we use to properly align the device with the native cusps. Then you have to position it. Once you position it, the locators clip onto the native leaflets. Now we're talking about a non-calcified substrate or target. So this forms a seal and stably secures the valve, and then you deploy the frame, the self-expanding frame, which is a second point of fixation and opens these large cells to access coronaries with some flaring of the inflow ring conforming to the annulus. So it's a very defined process which has some very unusual features. And as Joe mentioned, there is another device that is similar to this, the J-valve, that we will not be covering, at least in this talk. The purpose of the Align AR study was really to study this device, this dedicated device, for AR in a group of patients that really fulfill the criteria that was needed most. Symptomatic 3+ or greater AR at high risk for surgical aortic valve replacement. And that's the Align AR study. I don't want to go into too much detail, so I'll move a little bit more quickly. After identifying these patients, they have appropriate clinical evaluations, echo, functional evaluations at various time points. There is a 30-day primary safety endpoint, a 1-year primary efficacy endpoint, and these are compared with pre-specified performance goals. This is a prospective observational study as opposed to a randomized trial because for a variety of reasons, this was not a population that was easily randomized. I've had the opportunity to work with JenaValve for the better part of a decade now. I mentioned our 2 principal investigators. I want to specifically mention some other people. The highest enroller is Raj Makar, who's at this meeting but not here today, I believe. I want to mention some of my European colleagues, Stefan Baldus and Henrik Trady, who really led the way before us and made seminal contributions to this study and everything related to the use of the JenaValve in aortic regurgitation, and Matty Adam is right among that group. The core CT lab was run by Omar Khalik, the echo lab by Nadira Hamid, so we had very close access to high-quality imaging people. These are the 5 sites that enrolled the most number of patients. I'll mention again Raj Makar, and you just met in the previous session, Sushil Kodali, who worked with Torsten Wahl at Columbia, and of the 180 patients, just those 2 sites enrolled 76. So the inclusion criteria I mentioned, we did exclude certain things. So we excluded, of course, bicuspid disease, congenital unicuspid disease, large aortas, and a variety of other things, but not too many clinical exclusion criteria. The primary safety endpoint was a composite of several things that are part of the VARC2 definition at 30 days. The primary efficacy endpoint was very simple. All-cause mortality at 12 months. There were many secondary endpoints that we looked at, all the things that we would normally look at in a clinical trial like this, with very careful examination of the echoes, quality of life measures with patient-reported outcomes, looking at the KCCQ scores, and a variety of other things that you would want to know from the standpoint of clinical outcomes. How do you develop these performance goals? Well, we looked at contemporary high-risk AS trials, several of them, over 1,100 patients, to come up with what we thought was a reasonable index of safety at 30 days for a TAVR system in a similar age and sex-based population, and came up with a safety number of a composite endpoint, which using non-inferiority designs allowed us to be able to have a non-inferiority margin for the composite safety endpoint. For the performance endpoint, again, there isn't that much data in the literature of untreated, severe, symptomatic aortic regurgitation, but the data that we have indicated that depending upon symptoms, that the weighted average mortality based upon what we enrolled in this study would be about 30% in this group. We reduced it slightly for the sake of discounting based upon using performance goals. So the efficacy endpoint was to achieve a less than 25% mortality at a year, again, using standard non-inferiority methods. Of course, we had core labs and CEC adjudication, and this study will be followed out to 5 years. Some of the patients that were screened were not included. Joa mentioned some of the reasons. Some were CT anatomic criteria. So for instance, if you had too large of an annulus, which was the case not uncommonly because we had limited valve sizes, you were screened out. If the AR was thought to be moderate or less by echo criteria, and I want to again emphasize the difficulty it is using the ACE criteria to have a precise echo diagnosis. And then there were some other clinical and anatomic criteria that we don't have time to get into. So we enrolled 188 patients, of which 177 had the Trilogy valve successfully implanted. Who were these patients? They were older. They were 75 years old on average, almost an equal number of men and women, which is a little bit unusual. The average STS score was 4.1, even though these were high surgical risk patients. And here again is the fault of looking at STS scores to try to grade the surgical risk status of patients with aortic regurgitation, as is the case, for instance, with mitral valve disease. We retrospectively and in a blinded fashion had surgeons looking at all of the a documentation for risk status to be able to adjudicate that these were high surgical risk patients. 2/3 were class 3 or 4, 1/3 were class 2, a variety of other comorbidities as shown here. More than 40% had atrial fibrillation. 20% had coronary disease. Many had previous conduction system disease, and 16% had a prior permanent pacemaker. The baseline imaging shown here, as I mentioned, moderate severe in 96% of the patients. Some of the other things that you would find on an echo, these were not grossly dilated ventricles. Again, similar to what Joe had mentioned, for the most part, ejection fraction was reasonably preserved with an average of 54% ejection fraction. They did have LVH. The annulus perimeter on average was 79 and area was 480. The procedural details, we did use general anesthesia and transesophageal echo guidance in the majority of these cases because we were learning how to best locate these the device from the standpoint of positioning and getting the locators and confirming their presence in each of the sinuses. Procedural time was a little over an hour, not much contrast volume, rarely post-dilatation. Almost 60% were the larger device, with 20 and 22% of the medium and small device. If we had an even larger device, we would have been able to enroll more patients. Procedural outcomes were strikingly good. We had some valve embolizations, and I think a lot of that was getting used to the system and some other subtleties that we can discuss. Otherwise, really from the standard technical device procedural success standpoint for a new TAVR system, actually this device performed very well. Looking at the primary safety endpoint at 30 days, you can see very low numbers of the standard clinical outcomes we look at, including mortality, stroke, bleeding, vascular complications. The one thing that does stick out, because it's part of the composite endpoint, was new pacemaker implantation was 24%, higher than what we had predicted and higher than what was seen when this device had been used in aortic stenosis. Maybe something that we can discuss. So when we look at the primary safety endpoint at 30 days, the rate was 26.7%, and the upper one-sided bound of the confidence interval put it well below the pre-specified non-inferiority margin. So at least from a standard clinical trial point of view, it met the non-inferiority endpoint for safety. For efficacy, it did even better. The overall one-year mortality was 7.8%. The upper one-sided bound was 12.3%, much, much lower than the pre-specified non-inferiority margin. So again, both the safety and efficacy margins relative to performance goals were met in this study. We learned a lot during the trial. This is breaking up the study into 3 terciles, and you see the pacemaker rate started as high as 30%, and by the last 60 patients was down to 14%, as we learned how deeply to implant this device from the standpoint of where to position the locators, and also how to correctly size this device. It doesn't need to be oversized to the extent that we had previously used TAVR systems in aortic stenosis. So this is something to keep in mind. What struck us as really remarkable was the hemodynamic valve performance of this self-expanding short frame device. So the EOAs, as you can see, were 2.7, 2.9, 2.7, strikingly high, with less than 5 millimeter mean aortic valve gradients. Now, granted, these were not AS valves, but really strikingly good hemodynamic valve performance seen in this AR study, with the lowest frequency of significant paravalvular regurgitation that we have ever seen, including mild PVR, which was in the range of, and it was interesting, and this was a consistent observation, that it got better over time, that between 30 days and 6 months, that the amount of PVR went down significantly. We saw consistent LV remodeling, which began at 30 days and tended to reach a nadir by between 6 months and a year. We saw impressive LV mass regression. We didn't expect it would occur so dramatically, so quickly. We saw a dramatic improvement in New York functional class. As you can see here, 90% of these patients are class 1 or 2 out to a year now, recognizing that 2/3 was severely symptomatic, and more than a 20-point increase in KCCQ overall scores. And to put that in some perspective, that is one of the highest increments than we've ever seen in a clinical trial. Now, granted, this is a registry and it's unblinded, but still, this is beyond what you could imagine from a placebo effect. So in this population, I think that we nicely demonstrated that this device was safe, that the efficacy was at least as good as we would have imagined in terms of improving 1-year mortality. The new pacemaker implantation was something that we still have to continue to work on, which we think we have a better understanding of. The valve performance from the standpoint of antegrade gradients and large EOAs and paravalvular regurgitation is strikingly good. And we also saw significant improvement in LV remodeling and quality of life and heart failure functional status through 1 year. So this is a new TAVR system for a new indication. And I think that this first trial really sets the stage for where we can be going in the future. We've demonstrated that patients get better. We've demonstrated that their quality of life improves. We've demonstrated that this device, after proper training, certainly is safe within the range of safety that you would expect from a new TAVR device being used currently for either aortic stenosis or aortic regurgitation. We're struck by the quality of the valve performance and some of the other echocardiographic outcomes. So we are now just beginning to understand the potential use of a device like this for aortic regurgitation. So the Trilogy system now provides the first dedicated TAVR option for symptomatic patients with 3+ or greater AR who are at high risk for surgery. And this may become the preferred therapy for this patient population. But I also think it will set the stage for future creative clinical trials, especially in patients with other anatomic scenarios, including earlier stage disease. Thank you.
Thank you very much, Marty. And we have a few minutes. I have a question to Matty, and then one more question for you, Marty. Matty, you have a lot of experience with this valve, and it looks like this valve has something that all the other valves are striving for by specific techniques. This valve is something by design, commercial alignment, implant depth. Would you, and in Europe, this valve is approved for aortic stenosis and aortic regurgitation. Would you briefly give us an idea on how this valve performs in aortic stenosis versus aortic regurgitation?
Thank you. But I mean, clearly this is an AR session, but to extend this a little bit to the aortic stenosis patients, it has been easy to implant in patients with aortic stenosis as well, because you already have, by definition, with the locators, commercial alignment, low stand frame. The pacemaker rates were strikingly low, so I think the pacemaker rates, which is always a great discussion point, I think it's different because AR is different than AS, and if we use the same valve in our AS patients, pacemaker rates goes down a lot. It's below 5% in the registries we found it. So I think there is a future for this valve above or beyond AR, and we should keep this in mind. So I have to say, for AR, I mean, it's the dedicated device that really gives us an advantage over non-dedicated devices.
What caused the significant change of pacemaker rates, in your opinion?
In my opinion, it's a lot about the oversizing. Marty already mentioned that. I think the oversizing, you need less oversizing because of the different mechanism that the valve enables with the clipping. And also in AR, I think you don't need as much oversizing as you would need in AS.
Marty, quickly a word about what do you think the next steps would be, future trials with this device in regard to aortic regurgitation?
It's a great question. I think everybody can speculate on that, but I think that assuming these data are going to be sufficient for the FDA to allow us to approve this device in the U.S., that would certainly generate the impetus, and we're already planning what the next series of randomized trials would be. And it would be for a much broader population of patients with aortic regurgitation, using as a control arm what is currently being done with surgery, and looking at a variety of clinical and imaging endpoints to help us understand if this device has a role in both treating lesser degrees of aortic regurgitation earlier, what its parity is with surgery, and how we can begin to affect the guidelines so that the trigger point for when to intervene in AR patients can be appropriately adjusted in the future.
Yeah, thank you very much. And I would like to summarize what we have heard and what the key learnings are. I think what we've learned is beautifully demonstrated by Dr. Cavalcanti, that how important imaging is, how we have to differentiate moderate and severe, that we have to intervene possibly earlier before fibrosis is going to start, and that the guidelines are way behind. As far as the Trilogy valve is concerned, we learned the excellent performance of this particular valve, not only in terms of safety and efficacy, but also how easy this valve is to be implanted. I think what we see here is that by design, this valve fulfills the criteria of, if we call it next generation valve, not only possibly for aortic regurgitation, but also possibly for aortic stenosis. We had heard from Marty some future options on when to use this valve and what indications, and some idea about future trial designs. With that, I would like to conclude the session. Thank everyone, the audience, to be with us, and obviously the discussants. Thanks very much, and have a successful PCR. Thank you.